gonna be this one. And then share. Okay. So there we should all be all set. Can you see the screen?
Yeah, all good.
Yeah.
Cool. So let's get started. So let's go through the case. There was one case that we left from last time. It should be case 72. So that's the history. It's an 8-year-old cat, a female spayed, decreased appetite, weight loss, polydipsia, and vomiting. And let me share this link. So I'm gonna copy, I'll do this. So those are the images and this is the link. And I will share it through chat, which should be somewhere here. Okay. Okay, so that's the link if you want to look at the images. Otherwise, I'll open the images and then we share. So rounds should be case 72. Oh, and then, sorry, I need to do something else, which is to kill this monitor. Okay. Good. So now there are 3 images. These are the 2 laterals. And then this is the VD. Okay, so take a look. Again, you can go either way. You can look at the images through my, like, whatever I'm showing, or you can just open the link. And then after a couple of minutes, whatever, you just let me know. We start going through the abnormalities. Meantime, I'm gonna look for something. Okay, any comments? Everyone is very quiet, or I don't have any sound?
No.
Okay.
We are quiet. On the VD, the left kidney seems, the size seems increased to me. And
Cool.
the descendant colon seems to be like deviated towards the right.
Okay.
Well, actually, not only the, like, it seems like all the intestines that are filled with gas, and so that I can see in the VV, they seem to be like displaced towards the right and caudally.
I agree with that. So it seems to be caudally and probably to the right.
Yeah.
I'm trying to stay away from agreeing or disagreeing yet, because then so then we all like bring stuff, then you argue. Makes sense? So hopefully there will be someone that either agrees or disagrees with you. Makes sense? So it's not gonna be me agreeing or disagreeing. That's why I'm trying to stay quiet. But so your comments are that, correct me if I'm wrong, it's only the left kidney, both kidneys? You think it's the left? So the left is enlarged, and that is resulting in the displacement of the colon and probably a small bowel.
Yeah.
Okay,
I'm not sure this is the only reason, but it seems to me that compared to the size of the animal, the left kidney is too big.
Okay.
The right kidney also looks big as well, I think.
Okay.
Yeah.
It's just a bit harder to see, I think, because it's got the transverse colon kind of running through it on the DV. But on the laterals, you can see kind of both kidneys there. The right a bit more cranial, and that's why you're kind of getting that divot. I'll draw it.
I think I can see it on the VV now. Yeah, draw it.
Oh, hang on. So I think maybe this is the caudal pole of the right kidney.
Yeah. This is what I was looking at.
When
Perfect,
you're kind of looking in the lateral, we're kind of looking at like, sorry, it's a terrible drawing, but you've kind of got the two separate kidneys kind of overlying each other there on the right lateral, and similarly kind of here, the two kidneys.
Yeah.
So I think there's bilateral renomegaly.
Okay. So let me draw here how I will go around the kidneys, which is in agreement with what you are drawing, but let me make it large. So, okay. And again, anyone can disagree. Okay, so the left kidney, I will go like this. And then the right kidney, I will go like this. So do you remember our grapes and everything? So this is a beautiful example of summation. Makes sense? So this area, it doesn't really represent any grape. Makes sense? So, or object. It's just a summation of the caudal pole of the right and the cranial pole of the left. And then we just create an image with the borders that they are from each of them. That doesn't really represent any structure, and it's more opaque compared to the rest of the kidneys because there are two kidneys. Makes sense? So, and we can still see the borders. So let me erase that if you want to take a look again. So that's a caudal pole, which is easy. It comes like this, then it comes like this. And then this is the right. And then there's this point where both are superimposed. So regardless, usually that's the way that I probably am not conscious anymore, but the way that I would suggest taking that is probably the easiest, because it's a more contrasting, is to identify this area of superimposition. But tell your brain that's not the kidney. Look for something more cranial and look for something more caudal. So if you identify these, which is very easy in normal, like in almost any patient, then it's going to be easy for you to identify this border and then this border. So yeah, so that's how it looks. It always looks like this. You are adding the point that it looks like both kidneys are enlarged. Okay, good. Anything else?
Cool.
Can you say that the left kidney, it's very clear to see on the VD, probably because it's highlighted by the fact it's either got I'm going to say possibly gas around it. It's possibly fat, but the cat doesn't look fat. And I think it's more like a gas opacity than it's somewhere between fat and gas around the left kidney.
Okay, so you are saying that in your eyes there is an increased contrast.
Yeah. Yeah.
Okay. And then your explanation is that the kidney is still soft tissue, but there has to be something with contrasting more than usual outside the kidney, and then you are speculating about the presence of gas. Okay.
Yeah. Yeah, I can't say any more than that.
That's okay. And then I leave it there, and then we'll vote. Okay, any other changes? Findings. As soon as we are done with that, then we'll go into the speculation, okay?
It may or may not be relevant, but I'm really struggling to see the bladder.
Okay.
I can't see a clear-cut wall of bladder.
Okay. Well, in the context of at least the hypothesis of enlarged kidneys, looking for the bladder is a good idea. Okay, so as everything, I just write it down and then we debate. So let's call it inability to identify the bladder. Okay. Anything else?
I was wondering about the liver, but the gastric axis seems to be normal, and the borders look normal. So I think it's normal.
Okay. Okay, do you want to, so I think there is one more important finding, but I'm not sure where to go, if to talk about the findings that are already out there or to guide you to another finding.
There's quite a bit of gas in the small intestine, but it also seems like one population as well, I was going to say. So whether or not that's suggestive of or normal, or potentially suggestive of some kind of ileus, it's hard to say. But all those small intestinal loops also seem kind of like, it's not, I don't think plication, but they're kind of, has that kind of ball look. So I'm not sure if that's just because it's being pushed away a bit like a Mass Effect, or if it's something I'm making up.
Okay, so there are.
I was going to say, sorry.
Comment. Yeah.
I was going to say the same thing. It's like there's a Mass Effect in the sort of cranioventral abdomen, like where you'd imagine the spleen would be. Like it looks like the intestines have been kind of pushed dorsally a bit.
Okay.
I
so
can see something there. Whoops, that's not quite accurate. And you can identify a similar sort of structure here.
Very good. Very good.
That's a very wobbly line that's not accurate.
Okay, but now you can see it in 3 projections. I will probably, as an exercise, argue and ask you, are you sure that's not kidney?
I would say on the laterals, it's too far ventrally to be a kidney, unless it's really weirdly placed.
Kidneys are very mobile in cats, so whereas I think it's possible, it's unlikely.
Yeah, so I think, so very, very good point in bringing that up. I think you use the proper words and then the proper findings. So basically, and it's not the kidneys, and I think that we can be very certain that it's not the kidneys. So there's a mass here, I completely agree that it's very likely to be somewhere there, and I completely agree that it's likely to be somewhere there. You can call it mass effect. The small bowel, if it's only being displaced by the kidneys, it should be ventrally displaced, and in this case, it is ventrally displaced, but it's also caudally displaced. So then this having an extra mass here, something else in here, would explain why the kidneys are behaving like that. And then if you want to even argue more and say, well, that's no kidney, you can see the borders of the three things. So the border of the right kidney, the caudal contour, this is an extra border, and it's something soft tissue sitting there. And then this is the border of the left kidney. So now you could separate the three, helping yourself with the three projections. We can see the three things in the three projections, and everything is behaving, everything meaning probably the small bowel, is behaving that there's not only enlargement of the kidneys, and that would result in ventral displacement of the bowel, but also in the caudal displacement of the bowel, and that's due to the additional mass in the mid-abdomen. So I would personally completely agree with that. I'm still open to anyone arguing against, and if you can, bring a good argument, then that always, brings the discussion forward. I'll probably want to ask the rest. So if I go through the list, then I think we are, okay, one point. So I have enlargement of the right kidney and left kidney. That's the first topics in the list. My question is, how certain are we? Is this a more or less finding? Is this a very clear finding? Should we grab it and run with it? Should we be careful with it? How certain are you? And what are your tools to decide about your certainty?
I thought you can measure it against L2, and I might have this wrong, but it's I think it's 2.5 times the length of L2. Very good.
So I think I never remember the proper number, so I was just looking at that, and it's in neuter animals or castrated animals is 2.5. The length of L2. So and it should be in this projection. So if you have, so that's L2 is 2.5, 2.1. So it should be 4 something 5, and now we have 6.5. Okay, so that now we can add the word objectively. Makes sense? So it's not that we subjectively believe that the kidneys are enlarged. Now we can add to our report and also to our understanding that there is an objective. It's not that we are guessing. Based on the rule, there is an objective enlargement of the kidneys, and it's both right and left. Okay, so that's very good to clear up if there is any discussion about that or any I cannot erase. I don't know why. Okay. The computer is having a moment. Okay. Anyway, we'll leave it there. So enlargement of both kidneys. So we are all in agreement with that. Let's discuss about the comment about the increased contrast. So I want to put that to the group. What do you think about it?
I'm not convinced about that.
So then you are saying that there is normal contrast or reduced contrast, or remember that last time when we had the lepto case, we were like this loss of contrast was a key element. So it was the opposite. It was like reduced contrast. We couldn't see the contrast of the kidneys very well. And then our reading of that situation was that there was a bit of fluid around. So, and that was a very, very important feature. So your ability, the borders of the kidneys are always very important. And now there is a point, we see them too clearly. So, you agree, disagree. If you disagree, why is that you disagree? So you need to convince the person that made that statement that is wrong or right.
I would say the contrast around the kidneys is pretty good. Like you can clearly see the edges of the kidneys compared to last week. I think the serosal detail in the abdomen in general isn't that great, but it's a really skinny cat. So like it could just be because it's thin.
Mhm. Remember that the argument here is that there is increased, not decreased. So
sorry, I wouldn't say there's increased contrast to me.
So the way that I would react to the comment is, so there are only two possibilities for it to be, or one possibility to be increased. And is that, or yeah, that's two. So one is that if you add gas, so, how can we end up with no more retroperitoneum? And there are situations where we can end up with that. So it's worth considering. So as far as I know, the most common situation where you may end up with no more retroperitoneum is secondary to the pneumomediastinum. So remember that anatomically they are connected.
Okay.
So if there is, I don't know, a ruptured trachea, and I may have a case. So ruptured trachea, plenty of gas in the mediastinum. It may even break into the interpleural space, pneumothorax. It's very likely that that case, and usually in cats, usually traumatic, is going to result in gas in the retroperitoneum. So that is a possibility. I would probably consider that option. The clinical presentation doesn't look like that. And then if you go by the images, the thing that is going to probably the argument that I will use to say that it's unlikely or that there is no pneumomediastinum, retroperitoneum, is that if you compare the opacity of the fat here with the fat, sub-Q, and then you compare how gas looks like, gas looks a lot more black. So, and then the way that gas is going to behave, it's not only going to produce more contrast, it's going to try to go, it's never going to be, unless there's a huge amount, it's usually never going to be homogeneous like fat. It's going to be like more triangles. Makes sense? So it's going to go between these two structures, and then you get like a patchy situation. Very sharp, very well defined, because then it's going to be gas contrasting very much with, or very strongly with other borders. But I don't think we are dealing with that in this case. I think the reason why, now I'm going to try to explain what is happening, and I'm trying to read your mind, so I could be completely wrong. The reason why we see the kidney so clearly, and probably we want to find an explanation, is because of the massive head. Usually the kidneys are superimposed over the small bowel. So then we are trying to find that line in between the other lines that are superimposed. Now, because the kidneys are so large, the bowel is all displaced. So then we are left with wall, kidney, and wall. Makes sense? So there's almost nothing superimposed over those kidneys to bother us. So then our brain kind of picks that line very nicely. And then probably we need to find an explanation. And your hypothesis is a very well taken hypothesis, but it's like every hypothesis, we need to take it, see how far we can go, and if we can go very far, we come back. Make sense? So that's how I would go.
Okay.
Would also just the kidneys being bigger and therefore thicker make them brighter than normal, like just because of the thickness, like it's bigger?
That is absolutely true. So if the kidneys are thicker, then again, we go back to the grapes, there is more tissue. So remember that the opacity in a radiograph is given by the composition, in this case it's soft tissue, but also by the thickness. So if you have like a very large kidney, then it's going to be more opaque. It's still going to be soft tissue, makes sense, but it's going to be more opaque. So that perfectly fine. So that would be another explanation to say it's not so much that the tissues surrounding the kidney are reduced in opacity, it's that the large kidneys are increased in opacity. And therefore I see them more clearly. Perfect, beautiful explanation, yeah. I think it's a combination. I think it's that plus that you don't have anything superimposed. So then you can just pick the border like this. Okay, so those are the findings. Now is the hypothesis, what is going on. And probably the interesting thing is how far we can go. And before we go there, let's bring it in a minute. Okay, so I want hypothesis.
Given that given that it's an aged cat with bilateral renomegaly, I'd suggest lymphoma until proven otherwise.
Okay. Okay, lymphoma.
I guess,
How old is this animal? Sorry.
I guess just like anything that inflames the kidneys, like acute kidney injury, pyelonephritis, anything
Okay.
that just kind of does that.
Okay, so that probably we could group all of those into an acute nephritis.
Yeah.
Okay.
Yeah, acute.
Okay, what else?
I guess it
But
would be
then, sorry,
Ex-
you go.
extremely bad luck, but simultaneous bilateral urethral obstructions.
Okay, okay. So then, well,
I think that's unlikely, but
no bad luck. We need to add one condition to that hypothesis. I really like the hypothesis, and there are many situations where we end up with an image like this, secondary to obstruction of the ureters. But there is something else that we need to add to that hypothesis to make it, to explain why it's bilateral and almost bilaterally symmetrical. Okay, so I'm gonna write it here. So the the way to group all of that, I'm gonna put hydronephrosis,
yeah.
and then we're gonna discuss a bit more about that. Okay, what else?
There's also that unidentified mass in the sort of mid-ventral abdomen.
I agree.
Yeah, if it was like acute nephritis, how would that go with this mass that is
Okay,
Would that
Okay,
make
so
it explain?
this
Could that-
mass is if we want to include it, which I think we should, into our considerations, then probably that's gonna help us organize our differentials slightly different. Makes sense? Because I agree. If there is acute nephritis, how can we either there are two separate disease processes, or then it's unlikely for it to be acute nephritis. Makes sense? Because then how can acute nephritis explain the mass? So I agree with that point, and I would certainly go that way. Yeah, very good. How is that mass going to help you prioritize the list? Well, how is that mass going to help you go put one of the differentials higher? Or which differential do you think is more likely if you consider that mass?
Makes
maybe neoplasia?
Yeah. Yeah, so I think they comment before about lymphoma. I
Yeah.
think because the position of that mass, we haven't talked a lot about that, but okay, we can, okay, I leave it there, and then we will discuss, based on the position of that mass, even if we just ignore the kidneys, which structure can look like this?
Spleen.
Could it be like jejunal lymph nodes?
Okay, so options are spleen and jejunal lymph nodes. Anything else?
I guess could it maybe be a primary intestinal mass, like non-obstructive?
I agree, yes. So it will be small bowel. Those are probably my top differentials. I would like to be correct and really correct. Oh, I don't know. I was thinking maybe pancreas could be. It could, but it's caudal to the colon. Pancreas, I would expect it to be more sitting here rather than here, so probably not. Now, if I take those spleen, jejunal lymph nodes, or small bowel, I'll probably try to find the spleen, and then the spleen looks very small, so even though we cannot rule it out, it's probably less likely. And usually the spleen, see that it seems to be in the mid-abdomen. It seems to be that the bowel is surrounding that mass. It's not that the mass is displacing things dorsally. So again, this is thin, and I will never remove spleen out of the list. but because it's sitting kind of in the middle of the abdomen and the small bowel is kind of sitting around, I think that's a classic presentation for a jejunal lymph node. The spleen usually sits more ventral and it's going to result in dorsal displacement of the bowel. And then the other differential was small bowel, which again, I will not remove from the list, but it's what it is probably, I would expect in a small bowel situation is some degree of obstruction. Again, it's not all the time, so then I cannot remove that from the list. I will keep the three in the list, but probably I will put a jejunal lymph node on top of that list. And then if you put that on top of the list, plus the bilateral enlargement of the kidneys, I think lymphoma is way, 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 way up in the list. Makes sense because now we have a lot of arguments to have that hypothesis. The other one, so anyone arguing against acute nephritis? Any other argument?
Just question how likely it is to be bilateral if it's an acute kidney injury.
So, well, but it could be. I mean, well, probably you are thinking, I would expect, I think depending on the underlying disease process, like, remember, if it's an infectious and systemic disease and hematogenous, I will be okay with the bilateral. If it's ascending and there's some degree of obstruction of the collecting system or urinary tract, then I would expect to be more asymmetric. So
yeah, okay, what about a poisoning like Lilly or antifreeze?
So I'm not sure. So in my mind, the group is nephritis, including toxic insult. So in my mind, it could. I don't have experience with those particular, and I'm not sure if they result in such an enlargement of the kidneys. But I would certainly put acute nephritis in the list. The argument that I would use against my own hypothesis is that usually when there is acute nephritis, there is some fluid around the kidneys, like we've seen with lepto. And in this case, the borders are very well defined, telling me at least that feature, which doesn't need to be always present, but there's a feature that we want, is not there. That's why that plus the mass, I think, would make me think that acute nephritis is not, we cannot exclude it, but it's lower in the list. There are two things that are not really fitting. And then, yes.
Feline infectious peritonitis, I think it can result in kidney enlargement, I'm not sure, and in enlargement of lymph nodes, but this is an adult animal. I don't remember the age, but it's not a young animal, yeah?
FIP, okay, yes. Then I wanted to discuss the comment about chylomicrosis. So if we think chylomicrosis is secondary to an obstruction of the ureter, so let's assume that there is a urolith, and then the symmetry here is something that we don't expect. However, and it's uncommon in cats, but it's worth thinking about this because it's common in dogs. If we put the obstruction in the triangle of the bladder, and that's going to be the classic case in a dog with a transitional cell in the bladder. So if we have an obstruction where the ureters are entering the bladder, then we can have like a bilateral, almost symmetrical chylomicrosis. Make sense? So I think that's a good idea. I think it's unlikely in this particular case, but even chylomicrosis is a good idea when the kidneys are enlarged. Okay. What would you do next? And
ultrasound.
Yeah,
ultrasound.
We've been going around the limitation of the radiograph. And if you think about the considerations that we had, was like, is a collecting system affected? Is that enlarged kidney because the collecting system is enlarged? Is it because there is a neoplasia? Is it because there is inflammation? Makes sense? So which compartment, which part of the kidney is affected? And for a radiograph, it's all the same. ultrasound can give us more information. And in addition, in this case, it can give us more information about the other mass. So before we move there, because I do have an ultrasound, I just wanted to share this. And the way we've been around this, but we haven't been like strictly around it. So if you go in the book, the kidneys are a beautiful example in how we use features. So size, shape, and by shape, probably we need to include and contours, okay? So we are not gonna go through the table, but I suggest you do. And again, it's a beautiful example. I remember talking in lecture about this. I don't know how many picked this idea. But again, it's a beautiful example that we can very much divide diseases based on how they look. So if there's mildly, and kidneys are bilateral or unilateral. So that's one big group. And then if they are mildly enlarged or markedly enlarged. So mildly or severely enlarged. And then if the contours are smooth or the contours are irregular. So if you break that down, so now you see why it's so important to pick all of these findings, and really because depending on your finding, you're gonna go through one list of differentials or another list of differentials. Make sense? And then also if you go into the small kidneys with smooth or irregular contours. Make sense? So basically the list of differentials is gonna change. And I always go around with these lists because sometimes I forget exactly. And then, but I force myself to go through the change. So a large or small, regular or irregular, probably that's the most important. If we go into our situation, we had markedly enlarged, smooth outline, and it was bilateral. So we are in this list. And we consider hydronephrosis, lymphoma, FIP, and the one that we haven't mentioned, and then we should, is there any collection of fluid or tissue subcapsular, around the kidney? So that would be another consideration. And it's not, it's not that I have seen like 100 of cases, but once in a while, this weird case shows up. Okay, so it's gonna be a pseudocyst. So basically what you are seeing is not actually a kidney, it's fluid around the kidney. Unlike the grape surrounded by fluid, you can't separate. And ultrasound is going to be helpful in separating. Again, this comes back to the principle, to boiling down why is that we insist in describing the morphology of things. Things with different shapes are going to point to different disease processes. That's the conclusion. And kidneys are a beautiful example of that. Okay, done with that. And now let's go with the ultrasound in this case. Here we go. This one. Okay. Okay. So it's not that I have like a crazy amount of images, and the images are not that good. So basically, and this is from my time. Oh, so this is from Sydney. I thought it was from Surrey. Okay, anyway. So this is all we have. This machine that we change after. So this is the kidney. Interestingly, there is no fluid around. So that's good. That is in agreement with what we've seen. However, there is this hypoechoic or anechoic halo or band kind of surrounding peripheral, you can call it subcapsular or perirenal. We are going to talk about that in a minute. And then there's this hypoechoic, elongated, slightly heterogeneous, solid structure, which I think is a lymph node, and then these are the two lymph nodes. So that's as much as I have, so I don't have all of them. But it's just this image. If I'm trying to help someone working in the clinic and I see those radiographs, if you show me this is already telling me a lot. Makes sense, because to start, the hypothesis of the hydronephrosis, then we can completely rule it out. Makes sense, there is no hydronephrosis here. There is no fluid around the kidneys, there's this halo, and this has the appearance of an enlarged abnormal lymph node. So, we keep on going up with the hypothesis of lymphoma. What I would do in this case is probably take a sample from here, put a needle in here in the lymph node. And I think that's going to resolve the case. What I wanted to show you hopefully I find it, is this, because this is kind of the continuation from last week. And I think it's also a continuation from one of the cases that we have in the clinic. And it's this idea about, and the idea is an ultrasonographic comment. So what are we gonna do with this hypoechoic halo? And I remember someone asked me, I don't remember even who, and I remember saying, well, in my mind, it could be around the kidney, and that I would call fluid, perirenal fluid, or it could be subcapsular, and then I would be thinking about lymphoma. And then I remember putting the Doppler and saying, you know, the Doppler, sometimes morphologically, it's very hard to differentiate option A from option B. But if you put Doppler and if you see Doppler, then that is an indication that is subcapsular, and the way that we need to be thinking about lymphoma. So I went back to the book and to the papers, and I was glad that I wasn't wrong. And basically says the same thing, so I can't remember right. So it's difficult to determine if it's subcapsular or perirenal. So then in the book, they are considering both together. I suppose if you have a very high resolution probe and linear, you may be able to make the call easier. And then if you have, like, if there's fluid, those are the ones that we should be thinking about. So it's kind of acute nephritis or leakage of urine. So I don't know, hit by a car, rupture of the kidney, rupture of the part of the ureter, I suppose, hemorrhage, abscess, acute renal failure, obstructions, toxicity, and then lepto like last time, or neoplasia. And then if you decide that it's subcapsular, then basically you need to be thinking about lymphosarcoma. It's not the only differential, because there could be some other malignant neoplasias that may result in an appearance like that, or FRP. But basically, this paper kind of argues that it's almost indicative of lymphoma. So summary, for that particular finding in the ultrasound, is try to decide if it's fluid around the kidney or if it's subcapsular. Doppler may help you make that call. If you see Doppler, you need to be thinking about lymphosarcoma or other, or less likely other neoplasias. And that's the reference. And then we talked about this last time, this perirenal effusion in dogs and cats. And again, there seems to be an agreement about how to think about these things. The differences are almost the same. Okay. Any questions? Or there is another case that is, but I think we leave it for next time. Oh, sorry. So once in a while, and probably until we have someone bringing a case from the clinic, I kind of get into the mood of a topic. So as I go through one case, then I think about another case that is in the neighborhood. So the next case is going to be a related topic. These are the images. I don't think we should start today, but it's still in the neighborhood. You know, it's going to be it's somehow close. You know, or yeah. So kind of similar case, not really similar, but in that neighborhood. So until we have something coming from the real life, pushing us away from this kind of big topic, I may probably keep on bringing cases that are familiar. Okay.
Yeah,
So
cool.
from the previous case, do you have any questions, any comments?
Did we ever establish whether we could see a bladder silhouette or whether
Good point. What about that? So let me go back, and then probably the discussion that we should have is if we, so your ability to see the bladder or inability to see the bladder, it has to be put in context you need to consider that together with the good detail or bad detail in the abdomen. Make sense? So whenever you need to look at both things together. So if you're trying to check where is the bladder, can I see the bladder? Immediately you need to say, if you see and it's well defined, normal opacity, normal borders, we are okay, no problem. If you can't see, then you need to immediately think about, is there good detail? Make sense? Because then the differentials are going to change completely. So if the bladder, if there is good detail in the abdomen, meaning there is no free fluid, then there are two options that I can think of. I'm not really need to go to the list, but I would immediately be thinking about two options. One is empty, the other one is in the wrong place. Okay, so empty. The other one is there a hernia? So those are the two options. If there is poor detail, then I need to be thinking, if the poor detail is because it's a thin animal, or because the bladder is ruptured, or because there is another cause for fluid and then the bladder is irregular. That would be the thinking, the ways that I will go. In this particular case, actually, I think I can see the bladder. I think it's small. I think that's a border. This is a very nice area to look for the bladder neck. There's always a triangle there. And if you come here, I think this is even better there. And I think that's the border of the bladder. So I'm not that concerned in this case. It looks small, but I'm not that bothered. But again, that should be the thinking. Can I see the bladder? Yes, no. If the answer is no, is there good detail or not? If there's good detail, I think there are two options, empty or gone, displaced. If there is bad detail or there is poor detail, then we can be thinking about rupture, other causes of free fluid. Yeah. That in my eyes, that's the way that I would run.
Perfect, thanks.
Cool.
And if you have any like in this particular case, you have any question, then the next step, if now we are talking about bladder, the next step will be ultrasound, in particular in a situation where there is poor detail, either because it's thin or because it's fluid. That's not going to give you a lot of information about if it's ruptured or not. And then remember that to check for the integrity of the bladder or the positioning of the bladder, we use positive contrast. And to check for neural or luminal lesions, like a polypoid cystitis or neoplasia or a urolith, we go with double contrast. So that's the rule. For location and integrity, positive. So where is the bladder? If the question is where is the bladder, you check for positive, the retrograde positive urethrogram, cystogram. And if the question is, the other question is different, is there a lesion in the wall? Is there a lesion in the lumen? Is there a urolith? Then you do double contrast.
Then you do the IV contrast.
No, you do double contrast. So you go
double.
Yeah, so the procedure is that you go with a catheter, you remove the urine, you put a little bit of contrast, minimal amount, like 1-2 mils. You kind of move it around so then it coats the wall or the mucosal surface, and then you go with gas. And then that's going to give you a beautiful idea. I mean, if you don't have ultrasound, you go with ultrasound. But if you don't have ultrasound, and the question is location, just use a iodinated contrast, just positive. And if the question, and that's usually the case in a situation where, I don't know, hit by a car, you want to know, and in a situation of hit by a car, the question is the integrity of the urinary tract. Then even if you have the best machines in the world, you are going to end up doing a positive contrast study. Makes sense? Because you need to determine if there's a leakage, and that's how we do it.
With those ones where you're trying to work out whether it's ruptured or not, how much volume of the positive contrast would you use to be sure that it's not? Because I've had before where I've done it and then I don't think I used big enough volume and it just didn't show a rupture.
So there may be a volume that people follow. I don't follow any volume. I go by palpation.
Okay.
So if you think about the urethra, then there is one thing that I will be very careful. And so if you are doing a positive retrograde urethrocystogram, so if you are doing that, you probably go in, remove the urine, and then you go out. You may feel the bladder there, and then you check the bladder. There I would use palpation or pressure. And I've seen many situations where there's a partial rupture, say, kind of a fissure, and you need to make some pressure, you know, to see the leakage, or make some pressure with a phone or something. So that's one comment. And then the other comment that I have, and you may want to do that or not, because you may say, well, if with this pressure, I'm going to put a catheter. So I don't want to make more pressure and see the leakage. I'm going to put a catheter, I'm going to rest the bladder. So you may not want to force, you know, but sometimes if you force a little bit, like normal pressure, you may just see the leakage, and maybe a small leakage. The other thing that I will mention for the retrograde urethrogram is that if you are doing that to start with, and you, because of the trauma is in the pelvis, and you think the problem is in the urethra, I would start injecting a very small amount, because you basically want to check where. And I've seen many situations where if you go the whole lot, there's so much leakage that then you can't see the urethra anymore. Make sense? So, and you want to know exactly where it is, because you want to guide the surgeon. You want the surgeon wants to know exactly where. He wants to decide the approach. So for that, go to the very, very last bit of the urethra, inject just a little bit of contrast. If you could do it under fluoro, even better, because you can control. You give a little bit, you see how it goes. And as soon as you see a little bit of leakage, you can stop. And then that's the most important radiograph, the very first one, the early one, because then the contrast that is leaking is not gonna cover or get superimposed over the urethra.
Cool, thank you.
So I think that those cases, they basically need almost like an individual discussion, like an strategy. You know, are you gonna go first in the bladder? Are you gonna go first in the urethra? If you go by the book, they will say, the book says, if you want to do this study, you're better off going first in the bladder, removing the urine, filling the bladder, and then the last bit is doing the urethra component. Now that I'm saying that, I'm thinking, is that if you have the intention to identify a luminal lesion in the urethra or a wall lesion? And the idea of doing that in that sequence, I'm going very far, but the idea of doing that in that sequence where you have the bladder filled with contrast, and then you're going, the last bit of the study is going to be the urethra, is you are going against pressure. So you are going to be able to distend the bladder. And now that I'm talking about that, I'm realizing after I don't know how many years that probably that is limited to a situation where you are looking for a luminal or a mural lesion. Probably if you are after a rupture, probably you're not better off filling the bladder first. You're better off doing the urethrogram first. I'm thinking aloud now. These cases I usually take one by one. You know, I just look at the radiographs and say, you know, what's the question that I want to answer, and then we make a plan based on that. Because you can basically screw the study depending on which is the first part of the contrast that you inject. That's kind of the message. You need to be careful.
Okay.
I don't know if the screw comment is a very professional way of saying it, but you can ruin the study.
Very useful advice too. Thanks, Mariano.
Well, good. So there's a case there for next time. Take a look. Hopefully we can keep on adding on the knowledge, because the discussion is going to be someone using the same tools that we use today. But hopefully we're going to end in another port. Make sense? So, but at the end of the day, it's using the same tools, and it's the same. It's in the family. You know, it's the same topic, big topic. Okay.
Cool. Yeah. Thank you so much.
Thanks, Mariano.
Thank
Cool.
you.
Mariano.
See you next week.
Thank you, everyone.